So I'm going to talk about when things get rough during phaco, when you have to abandon phaco, and what do you do exactly? Now there are so many alternatives. So why? First of all, when and why do you actually abandon phaco? When your machine goes bust, obviously, if you don't have a backup machine, phaco is a very step-intensive procedure. So one step goes wrong, very difficult to go to the other step. If there is any of the steps are compromised, you go ahead and you bail out of phaco. And the last thing is the most important thing. When you have lost confidence in continuing phaco, there is no shame in converting. Please understand that. So rather you convert than have a drop nucleus. And so what I would like to ask the audience, when you are actually, when you are having a difficult time during phaco, what do you opt for? Do you opt to go for, making him aphakic and do secondary IO later? Do you do an ECC from the same incision or from a different incision, or do you do an SICS? What's your procedure? Suppose you have to abandon phaco for whatever reason. First. Yes. Yeah. So some people, when you are not trained in SICS, this is what I found when I was teaching abroad. Many of these surgeons, the residents do not know SICS. So they keep continuing phaco till it drops. It was very easy for them. They just hand it over to the retina guy,
Very poor choice of words.
I need the... I think the joke was lost because you didn't put on the audio. Anyway, we'll go to the next one. So, as he said, my preferred technique is the SICS. Okay, and the main reasons are listed out there. It's usually sutureless. Sometimes you do put a suture. It's a separate incision. The astigmatic control is better, and you have a faster rehabilitation. So I'm going to go into we just talked about the Argentine flag. Now see, this has extended. So what I have done here, okay, in this particular case, we could have done a phaco, but when you're not, this is a very old case, went ahead, just converted it to a phaco. This, believe me, is the safest option. This is the safest option. There's no doubt about it. You can do a phaco. Of course you can do a phaco. But this is the safest option. Now coming to the second example, this is a phacolytic glaucoma. Severe loss, you can see. I'm trying to do the rhexis. The whole bag is coming with me. I tried my best. Finally, I just opted to take out the lens, the bag, and I put a retrofixed iris clip-on lens. And here, this is a very hard cataract. I'm doing the rhexis. I have lost the rhexis inferiorly. Now, when you lose the rhexis inferiorly in such a hard cataract, it is not worth continuing with the phaco because you have all the chances to drop it. So just done a transconjunctival SICS, got it out, saved the day. No big deal there. And now this is another case, almost a similar case, but see what happens. When I am doing the rhexis, I've lost it superiorly. So when I lose it superiorly, I think I can still go ahead. I tried my best, but then it became very difficult. So again, just converted it to SICS, came out, and when you have already made some disassembly of the nucleus, believe me, it's very difficult to do SICS then. Very difficult to take out these pieces. The best way is to put in visco and visco express it out. And this is another case, this is a pseudo exfoliation, very hard cataract. Just watch me. I'm at almost 90% power, not able to break that nucleus. So I have to admit it, there are loose zonules there. Just come out, go ahead with the SICS. I'm just cartwheeling it out. I've done only a sort of a trench, no big deal. Put in the lens and look at the beautiful result post-op the next day. He's got 6'9", so why do you bother to go ahead with your phaco? And this is again a very old case. I'm doing a fairly good disassembly till I realized there's no posterior capsule. And then immediately bailed out, put in put in, took out the, all the nucleus. I'm reconstructing the nucleus outside to make sure that I got all the pieces. And then did a vitrectomy and put a rigid lens over the sulcus, into the sulcus. And here is, this is actually an intumescent cataract. The rexus ran away inferiorly, but I went ahead with my phaco. I realized the rexus has gone posteriorly, put in this thing, and the next day I realized that the lens is sinking. So came out, now I put in this is the best way to handle the situation. You know, cutting the lens intraocularly, trying to take it out through a small incision is all very nice to say. You can easily get out the vitreous. This is the easiest way, just put a small incision, get out the lens, put in your rigid lens. And this is a case, actually was referred to me, where's this? Actually, this is a very funny case, sorry. This was actually somebody attempted a phaco, okay? There is a, let me get this back. This doesn't work. Yeah. Oh no. Okay, anyway. My God, sorry. Can you put it on, please? Shall I put it on from here? It's the last slide. But this is very important. I'm not able to control this. Yeah, see, this is a 50-year-old lady. They tried to attempt a phaco. Obviously went with a blunt tip. And then was referred to me saying, I could not do the rexus. So he's gone in with the blunt tip, hit the lens, vitreous has come in forward. So I've taken up, did a SICS, did a vitrectomy first, did the rexus, was able to do the rexus, but the bag was so badly gone, I had to remove the bag. No shame, I put in an AC lens, and she is having a beautiful result. So, I don't know what happened to the last slide, it's disappeared. And okay, anyway, that's the conclusion. So, I don't know what's happening here. Okay, just leave it there. Yeah. No, I don't know what's happening. Put that. Okay, that's the thank you slide. It doesn't matter. So, yeah. Oh, okay. This is the last slide, yeah.
Yeah.
So basically, this is my conclusion. So whenever you are in a tough situation, it's better to abandon phaco because phaco is pretty unforgiving. And assess your skills, choose a proper bailout option. In my opinion, I think SICS is a must-learn technique. And this is a presentation I'm supposed to be giving somewhere abroad. That's why I put that last one. Should adopt it to the basic training program. If you see, we are very fortunate in India where most of us learn SICS. It's not so abroad. They do ECC and then they go to phaco. So they have a lot of problems. So now they are now switching over. The residency, they are trying to teach SICS instead of ECC. So thank you very much. And I would invite any questions. Superiorly. I just ignore my phaco incision. You don't have to bother about your phaco incision. Very rarely you'll connect it. If you connect it, okay, go ahead, put one suture. But I have never connected. It's very easy. You can just go a little bit.
As you told, SICS also learn, but there is no harm in ECC because I want to say that whenever I face this type of problem because I am a temporal surgeon, phaco surgeon, so it is easy for me to extend that with the flap, corneal flap. And if you are good surgeon with the proper suturing, maximum three suture you need, and the suture should not be loose and tight. So there is 6-6 vision. Even in fact, in SICS, scleral wound healing will be 1.5, 2 cylinder will be there. So ECC is also a good surgery, and it will rescue your time and the same site. No need to go to the SICS also. But yes, SICS also learn. That I agree with you.
See, having said that, In your hands, ECC may be good, but I'm telling you in majority, ECC is almost a redundant procedure. It's not being done anymore. And in most hands, you're going to get very bad astigmatism, and the surgery itself, you're totally out of control because it's an open chamber. You're completely open chamber. SICS, you're still in a closed chamber. That's the advantage.
Okay.
In your hands, you have done a lot of ECC. Okay, you may be good, but I wouldn't do an ECC. I do ECCs sometimes, when I have very bad blebs, huge 2-3 blebs, very hard cataract, very old patient, shallow AC, I'll do a corneal ECC because I have no other place, because I have learned. But I know, especially residents, I'm sure most of you are training people. When you are training, it's easier to teach them SICS than ECC. Do you agree with that? And it is much
Yes,
easier
I
to
agree.
train.
SS should also learn. I agree on front.
ECC,
But,
the advantage, what everybody tells me, ECC, the advantage that we had with ECC is that we learned suturing. But there are other ways to learn suturing. You
Not
don't
like
have to do ECC. Please, doctor, I think the last talk we have.